This is the stapler. If what you got all you for. We're not talking about that today. Respiratory part 3. So now we're going to focus on 3 common obstructive pulmonary diseases: chronic bronchitis, emphysema, and asthma. When we think of obstructive pulmonary diseases, usually you'll see clinicians contrast those as a group with restrictive lung diseases. In your obstructive pulmonary diseases, generally speaking, they are able to inhale a full breath, but they can't let it out because exhaling is obstructed. In COPD, the inhalation goes like this, and the exhalation goes like this. If you want to mimic that at home, try exhaling through a straw and see how much longer it takes you to exhale. Contrast obstructive pulmonary disease with restrictive pulmonary disease. Something we won't focus on too much here, but generally speaking, in restrictive pulmonary disease, the lungs just can't expand to get the full volume of breath. Clinically, when you work with these patients, they will undergo spirometry testing, which measures how much air they can exhale. A common clinical tool is the forced expiratory volume and forced expiratory volume in 1 second. In your med-surg class, you'll discuss and consider how these 2 numbers would be different in obstructive versus restrictive diseases. My goal right now is just to introduce you to them so it's not brand new knowledge later on. Bronchitis. Inflammation of the bronchi. Easy enough, right? Bronchitis comes in 2 general forms: acute and chronic. Acute bronchitis, generally speaking, a viral or bacterial phenomenon. Chronic bronchitis, more often associated with things we do to our lungs, such as inhalation of noxious substances. Now, if you're going to ask me smoking versus vaping, because that question will come along, hey man, is vaping like safe and smoking bad? Because I vape and vaping is cool and it's not harmful to your lungs. Sorry, don't really have research out that says that yet. So, vape on. Yeah, just intuitively, probably not good. Probably not good. Nice thing about acute bronchitis is that if it's a one-time thing, then you don't introduce the element of chronic inflammation. In chronic bronchitis, you are inviting the pathologic consequences that chronic inflammation involve. So patients with chronic bronchitis are setting off an inflammatory response within their lungs over many, many years. This causes scarring of the bronchi and an inability for it to do its job. And one of the jobs is that it has to have enough expansile qualities to open and close. Scarred bronchi can't do that, and that's what leads to the obstructive process. This obstructive process eventually leads to gas exchange problems as well, clinical manifestations such as cough, Clinical manifestations such as clubbing of fingers. Now, you might wonder, why on earth would nail beds change in somebody that has an obstructive pulmonary disorder such as chronic bronchitis? It's due to years of inadequate oxygen delivery to the nail bed and the hypoxia-related changes that occur in an oxygen-starved environment for fingernails. Now that I mentioned it, check it out. You'll see it on patients. Oh man, club fingers. Chronic bronchitis, dude. In addition, chronic hypoxia can stimulate pulmonary artery vasoconstriction, which is a compensatory mechanism to get more blood up into the pulmonary vasculature and get more oxygen into the blood. One of our principles of patho is that although our body has compensatory mechanisms for many, many things, they're only meant to be used for a brief period of time. Long-term use of a compensatory mechanism ultimately will fail and then will subsequently lead to other pathologic events. For example, the pulmonary artery vasoconstriction in this case can then lead to right ventricle failure, because if there's hypertension in the pulmonary artery, it makes it harder for the right ventricle to push blood out of the right side of the heart. As the right ventricle then fails, blood will eventually back up into the venous circulation, causing things such as jugular venous distension. As blood backs up into the portal circulation of the liver, fluid can be lost into the abdominal cavity and form ascites, which is a collection of fluid in the abdominal cavity. In addition, the spleen and the liver become congested with blood that's not moving back to the heart, and those organs enlarge. That clinical term is hepatosplenomegaly. Further fluid backup can cause swelling in the feet, edema around the ankles, and this is due to the congestion within the veins and capillaries of the feet, which subsequently increases hydrostatic pressure, overcoming osmotic and oncotic pressure, and pushing fluid out into the tissues. Sometimes patients with chronic bronchitis, because of the lack of O2, will have a bluish tone to their blood and ultimately a bluish tint to their skin. It gives them the clinical nickname blue bloater. Contrast chronic bronchitis with emphysema. Emphysema is not a disease of the bronchi, it's a disease of the alveoli. There's your first point of contrast right there. In emphysema, the other point of contrast is that most often emphysema is a destruction of the alveoli that's kind of a secondary consequence to the obstruction created by chronic bronchitis. Alveoli get basically over-distended, overstretched. Think of it as a rubber band just stretched too far. It doesn't have that elastic quality to it anymore. Without that elasticity, the alveoli really aren't able to push carbon dioxide out anymore. Ultimately, the destruction of the alveoli causes pathologic changes to the actual shape of the chest, where the shape of the chest increases in its anterior-posterior diameter. Because the alveoli can no longer push CO2 out of the lungs, CO2 remains in the bloodstream, and these people are chronically hypercapnic. Now, we talked about respiratory failure before, and respiratory failure is ultimately a change in blood gases such that respiratory drive is severely compromised. Emphysema and chronic bronchitis are two pathologies that can potentially lead to respiratory failure. In many patients, chronic bronchitis and emphysema are two different pathologies that are co-occurring. And eventually, They're both brought together under the heading of something called chronic obstructive pulmonary disease. A third, but somewhat less common cause of COPD is asthma. I'm betting you're probably familiar with this term already. Childhood asthma is quite common. Asthma's pathologic definition is based on an exaggerated secretion of immunoglobulin E. It's a hypersensitivity reaction, and atopy, which is how I pronounce it, atopy, how other people pronounce it, is the main pathologic consequence. Atopy is a term that is defined as having a genetic predisposition to exaggerated immunoglobulin E, to otherwise harmless environmental substances. Pet dander. But people with asthma will tell you it's not just pet dander that can throw them into an asthmatic attack. Things such as upper respiratory infections can do it too, but the defining feature is this exaggerated immunoglobulin response. The nice thing is about asthma is that it less often involves the chronic inflammation and subsequent remodeling of the lungs that you see in chronic bronchitis and emphysema. Though, the longer you're nursing, the more you will encounter patients who have poorly controlled asthma, setting up the stage for chronic inflammation, and it actually acts as a contributor to chronic obstructive pulmonary disease. You can find this chart not in your textbook, but on the Lit Review service up to date, available through our library. I like this chart because I think it summarizes through the rectangle and three circles how these three obstructive pathologies can all contribute in some way to COPD, though not all of them need to be present to have a patient with a diagnosis of chronic obstructive pulmonary disease. For example, a patient could have asthma and chronic bronchitis, but not emphysema, and develop COPD. A patient could have just chronic bronchitis and not eventually develop COPD. There are patients who will have chronic bronchitis and emphysema that will not get COPD, because maybe they take good care of themselves, they're doing other things to prevent progression of their disease into that end-stage disease. I just want to focus for one quick second on hypoxic drive. In A&P, you learned about CO2 blood levels and how that created ventilation automaticity. In patients with chronic hypercapnia, that no longer functions in terms of driving ventilation. Those patients eventually switch over to a hypoxic state as their drive to regulate how quickly or slowly they need to breathe. I bring this up because clinically, when you're working with patients with COPD, sometimes you'll find clinicians cautious to administer oxygen in people that have a hypoxic drive to breathe. That is to say, if they're used to breathing and ventilating at a certain percentage level of oxygen, and then you supplement that oxygen, it may reduce their drive to breathe. This little chart is just meant to kind of compare and contrast between COPD and asthma, the onset, which is late in life versus early in life, the cause, which is smoking and things of that nature more often, versus allergens, hypersensitivity to allergens, and then the general reversibility of airflow. Where in COPD, it's a slow process, but the reversibility of things is not there as things are getting worse. In asthma, that's not the case. Things are generally considered to be fairly reversible once the hypersensitivity is halted, usually through inhaled medication. Before I wrap up obstructive pulmonary diseases. I just want to throw in there, I forgot to put this in earlier, bronchiectasis, which is a clinical term that doesn't tell you by examining the term exactly what's going on. Bronchiectasis means an abnormal widening of the bronchi and or bronchioles, and there are many diseases, some of which we'll talk about within this class, including tuberculosis, that can cause restructuring or reshaping of the bronchi and bronchioles such that they actually are anatomically dissimilar to their usual state. Bronchiectasis is a state in which the remodeling of the bronchi have actually produced wider than normal bronchi. So that was 3 major obstructive diseases, kind of in a little nutshell. A major contributing factor to this, especially for chronic bronchitis and emphysema, is chronic inflammation. Earlier in this talk, we talked about lung cancer, for which a major contributor to it is chronic inflammation. And I bring this up because chronic inflammation is such a prominent contributor to human pathology. We're going to revisit it again and again and again. In this week's material, I've included a short summary of chronic inflammation and the deleterious effects on the body that it has. It's one of the nicest summaries that I have yet seen. It's updated regularly, so it is current, and it will really help broaden your appreciation for how chronic inflammation impacts almost everything in our body and so many pathologies.